Welcome, everybody. I can see that the people are joining our webinar. Give a few minutes for people to join. People are still joining. Welcome, people. Welcome, everybody. We will make a start in 1 minute. Welcome to the people that are joining this webinar. I can still see the numbers are increasing. Great to have you here. Okay. We will start. Hello, good morning, good afternoon, good evening. My name is Richard Ledger, the Executive Director for the World Federation of Occupational Therapists. And it's my pleasure to welcome you to this webinar, which is one of a series of clinical webinars aimed at introducing rehabilitation professionals to the critical role of early rehabilitation following earthquakes. These webinars are a collaborative effort between international professional associations and our counterparts in Myanmar in support of those affected by the recent earthquake. Over the next few days, you'll have the opportunity to participate in different clinical webinars covering fractures, spinal cord injuries, traumatic brain injury, and amputation following an earthquake. They will be recorded and will be made available for those who are unable to join us today. Today's webinar will be focusing on peripheral nerve injury and provide important insights into safe early rehabilitation techniques and management. There will be an opportunity to ask questions. Please use the chat function or Q&A function in the webinar. If we don't have time to respond to them all, we can provide a summary of the questions and answers, and we'll upload those along with the video when the webinar is complete. If you'd like to be contacted in the future with updates about these webinars, could you please leave your name and email address in the chat so we can contact you? We know that early rehabilitation is a critical component of disaster response. It allows us to intervene at the right time, supporting people to optimize their functional recovery and most importantly, reduce the risk of long-term disability. We initiate rehabilitation during the when we initiate rehabilitation during the acute phase of care, we help prevent complications such as contractures, deconditioning, and pressure injuries, issues that can significantly delay recovery and impact quality of life. Rehabilitation also plays a vital role in maintaining the continuity of care. It provides a gap between the acute medical management and the longer-term reintegration into the community, helping individuals return to their lives as safely and as independently as possible. But it's not just about physical outcomes. Early rehabilitation addresses the psychological and cognitive impacts of trauma as well, supporting people at a time when they're most vulnerable. By embedding rehabilitation into our emergency response frameworks, we strengthen our healthcare systems. We create a more comprehensive multidisciplinary approach that not only responds to immediate needs, but also lays the groundwork for long-term recovery and resilience. It's now my pleasure to introduce Debbie Gray. Debbie is a senior occupational therapist originally from South Africa, where she completed her education and began her clinical career. After several years of practice there, she relocated to the United Kingdom and has spent over 20 years working in National Health Service hospitals, specialising in trauma and orthopaedics with a particular focus on hand therapy. Debbie has contributed to international emergency responses through short-term deployments, including to Gaza in 2015 and Nepal following the earthquake that same year. For 2.5 years, she has been based in Ukraine. Her work has included on-the-job training with rehabilitation teams across the country, focusing on trauma-related injuries, and where she's currently working in a burns unit, supporting staff and training local rehabilitation staff. Her experience covers a diverse clinical and humanitarian settings, and she brings a valuable role to the perspectives to the role of early rehabilitation and disaster response. I will hand over to Debbie and thank her in advance for her presentation. Thank you, Debbie, and thank you to everybody again for joining today.
Thank you, Richard. Hello, everyone, and thank you so much for giving up your precious time to take part in the webinar this evening. I'm going to share my screen now, and let's just make sure everyone can see. I think that will work. Right, can everyone see that then? Yeah. Okay. So I'm going to go ahead and, as we're talking about peripheral nerve injuries. And I hope this overview will give you more confidence to look out for potential injuries to peripheral nerves. When you're seeing patients with sometimes very, very complex trauma injuries, often with peripheral nerves, they are often the ones to be missed, especially in the early management of patients following an acute injury. So I'll introduce the topic and look at peripheral nerve injuries in the context of an earthquake and how to identify a peripheral nerve injury, looking at how we adapt our clinical practice and manage them and treating them, in looking at identifying common complications associated with peripheral nerve injuries, how we can try and prevent or manage these complications, as well as how to develop a basic treatment plan for peripheral nerve injuries. Oh, my screen's not, there we go. So quickly going over anatomy. Now, don't worry too much if you can't remember everything. This is why we have Google. We can Google everything, or we can use our phones or computers to help us to remember things, refresh our memories. But with the nerve anatomy, basically you've got your neuron, you've got your axon, which sends the signals, and you've got your dendrites, which are the receptors to receive those messages. So your basic nerve, and with your axon sending those messages, and the axon, if you can see on this on the screen, that's surrounded by your myelin sheath there, and the myelin sheath is that like fatty tissue layer that helps to conduct the signal. Around the myelin sheath, you have got some it's encased, the whole axon is encased in a type of connective tissue, and that's your endoneuron. And then these axons, each axon, they're grouped into bundles, and these are called fascicles. Now, around these bundles, these fascicles, you'll get another tissue, a layer of connective tissue, and that will be your perineum, and then so you've got these bundles of axons, and then around the encased with a whole lot of fascicles, you've got your epineuron, encased in your big nerve. So you've got different types of nerves. It could be that it's simple sensory nerve, and they are then transmitting messages from the endings where the nerves are, wherever that is, for tactile touch, and then it's sending messages back to the CNS central nervous system. And then the central, in terms of the motor nerves, you'll be sending the messages from the central nervous system, and those messages are transmitted via the motor nerves to your motor end place or your muscles. But you can also get mixed nerves, so you get a mix of the sensory and motor nerves together as well. And so peripheral nerves, in essence, you know, that's beyond the central nervous system. It's the peripheral nerves are what they link the rest of the body to the central nervous system. We're looking at causes of peripheral nerve injuries. You'll get your open injuries, your open lesions. They could be tidy, which is, for example, making of injury could be a blade, a knife, piece of broken glass. And then you get what I'm seeing a lot of now here in Ukraine, a lot of untidy open injuries. So you've got your blast wounds from bullets, shrapnel, severe burns, and your open fractures. And no doubt you've also been seeing some of them with your patients your side now, unfortunately. Your closed injuries as well, you can get by compression, which also hinder the blood flow to the area. So again, it could be compartment syndrome, the trapped limb, foreign body or a bone. Also compress the peripheral nerve injury, or sustained posture, maybe they're lying in a certain position, and the nerve was compressed for a while, something was trapping the limb, as we said, and causing pressure to that part for a sustained period. Another way is also traction ischemia, so it's a forceful pull on the nerve, so that could be due to fracture dislocation, on a patient that's seen before as well. And Nepal was a young girl who was pulled from the rubble. The building had collapsed, and it caused a lot of traction strain on her brachial plexus on her arm. So in terms of just an overview of the signs and symptoms for a peripheral nerve injury, acutely, when you're looking at the sensory nerves that could be affected, those types of symptoms you might find are that if a patient's complaining of a burning sensation or shooting pains or symptoms, or a tingling sensation. And when I'm talking about this, I'm talking about both arm or leg. Then if the motor nerve has been affected, symptoms would be a loss of power, muscles not working as it normally would, it's not working, and then associated loss of function because of that. Also, you might have abnormal signals being sent if the nerve has been disrupted in any way, and so they might complain of a feeling of electricity. That's acute, and then we're looking at if it's been becoming more chronic or post-acute since time of injury. Then there might, because of the disruption or effect to the sensory nerves or somatosensory system, they might experience, or you might observe, they'll get altered skin color changes because of abnormalities to blood flow, and sweating changes. It could be that the increased sweating or decreased sweating. Also, if the muscles haven't been working or been for a while, then you might see signs of muscle wasting. And also patients then compensating with their movement patterns because of the muscle weakness, and also perhaps also because they cannot feel as well, especially in terms of dexterity. So when we look at a classification of nerve injuries, I'm sure you've all heard of maybe a neuropraxia, but there's one classification system, and we're talking about it, sevens, and it breaks down to 3 levels. There is another one, and that's Sunderland. And Sunderland, if you look up that classification system, it breaks up axonotmesis, the 2nd level, into more detail. So with a neuropraxia, often from a compressive sort of injury from compression, the nerve is usually intact, but unable to signal. So axon's intact, but unable to signal. There might be some damage to the myelin on the area. And they usually recover anticipate it could be some days, but my patients will be 3 to 4 months for them to regain recovery and a motor function association with it. Then the next level of severity in terms of nerve injury is axonotmesis. So this is when the axon is damaged. So, but the structure of the nerve or the connective tissue around it is intact. So recovery will take several months. As my patients have taken up to a year or more to fully recover. And also it depends on how high or the level of the nerve injury, whether say it's right up the proximal part of the arm or leg, or goes towards the distal part. And recovery in these circumstances with axonotmesis may not, the patient may not achieve complete recovery. And if they don't have any surgical intervention, and especially if the injury, as I said, is more proximal. And the thing here to take into account is the distal end plate, the muscles, and if that degenerates prior to the nerve regeneration, then you're not going to have a functional outcome, good functional outcome. And then the last level is neurotmesis. So that's when the axon and connective tissue are completely damaged. If it's a complete cut of the nerve, and the nerve might try to regenerate, but surgery is normally always needed for any kind of good outcome. Going on to the next one. So nerve properties. So if we look at a nerve, they do not tolerate stretch well. They don't like being stretched. So they don't lengthen the same way that a muscle can, and might lengthen up to 6% to stretch it, but then they will recoil. And so beyond 10%, it usually results in damage to the nerve. And so bear this in mind as well. If a patient has been fortunate enough to have surgery early, for surgical repair to the nerve, then it's just thinking about them the very early stages of acute rehab, and thinking about the fact that we shouldn't be stretching that either. It's an initial phases of healing. So in terms of when we look at axonotmesis or neurotmesis, what happens with the damage that's being sustained to the nerve? The nerve is a process. It goes undergoes a process called Wallerian degeneration, where the distal part of the axon, distal to where the level of the injury was, that degenerates, and so in it leaves a hollow tube. Now you want a hollow tube. It doesn't always happen that way, because we'll talk about complications to what stops the nerve from regenerating, or hinders it. But you want this hollow tube for a nerve to grow, because it'll go from the proximal part towards the distal end. So if the patient needs surgery, this might not be picked up early on, and also that's why I'm highlighting this topic's importance, I believe, because often peripheral nerve injuries are missed. So often in the case of a disaster like an earthquake, when a patient, they've got so many complex injuries, got fractures, open wounds, then often the nerve has not been repaired straight away. But if they've been fortunate enough to have the nerve repair early, that's great. And then it might be delayed repair. So that might be a possibility of being detected. But then if we think about, and I'll talk about it in the next few slides, if it's been down the line and there's no chance of obviously a primary repair or a secondary nerve repair, we might be looking at tendon grafting. If they might later on, then if there's no chance of the nerve repairing, then they might have to look at tendon transfers, and then a functional fusion to the joints. And often what we need, we can use our role is critical in terms of also trying to prevent contractures. And because sometimes these patients will need a contracture release if they develop contracture because of lack of movement, for example. and so they'll need that anyway if they're going to be looking at any nerve repair, because you'll need a movement of those joints, obviously. So again, with the primary nerve repair, it's just stitching the two ends together. So you've got to have good length for the nerve, because we know that the nerve does not like to be stretched. So that's why it's so important and critical that you try and do it in the first few days after injury. But otherwise, the grafting, often patients, I've seen a lot of patients here, where they'll use the graft from the sural nerve, because that's a sensory nerve, and that's one that I can't say it's not important, but where it's located is not as important in terms of was under the foot, then there'll be a problem for feeling, having sensation or under the foot, but for the back of the lower leg there, that's it's okay. So they often graft the sural nerve, and they can take a large enough piece then to plug in where that nerve is defect. So in terms of outcomes of surgery, it's not always a guarantee that the nerve is going to recover after surgery. And also depends on the context. It depends on the surgical capabilities. It depends on the premorbid status of the patient as well. And it depends on the aftercare and the follow-up as well. And again, person smokes, for example. So positive indicators, as we know, if they're young, if it's an early repair, if it's a single function nerve. So if it's, for example, either a sensory nerve or a motor nerve, but it's more complicated if it was a mixed nerve not been repaired. And again, if it's the location of the repair was more distal, say at the wrist level or lower leg level, versus if it was higher up, because we know that nerve has to then travel a long way with its healing, recovery, regenerate in the process of healing. So the reason why I've said that is because nerve regeneration takes a long time. The rates of 0.5 to 2 millimeters today, well, I think 2 millimeters is a bit optimistic, to be honest, and especially if we're looking at the context that we are talking about. And so again, going from proximal to distal. So if we have a high arm, if it's a very proximal injury, then if you think about that 0.5 millimeter per day, it's going to take a long time. And the motor end plates need to be innovated within 18 months of injury, sometimes sooner, to achieve motor recovery. And the maximum recovery from nerve injury can take up to 24 months, 2 years. I mentioned tendon transfers, and tendon transfer is really when, and I'm seeing a lot here, where the nerve, they've tried a delayed repair or tried a nerve graft, and it hasn't been successful. But months and months and months and months apart, if not a couple of patients, it's been a couple of years. And so for these patients, it's functionally pretty devastating. They've lost a lot of function, especially if you think about, say, radial nerve injury. But if the patient gets the right specialist, right surgeon and surgical team, then there are options. There might be options for tendon transfers available. So this is taking, there are lots of criteria as to choice of muscle and what they will choose, and procedures that they will do. But for example, for a patient who's lost wrist extension, they can use pronator teres and reroute it to the extensor carpi radialis. Or for the foot. Now, I'm no foot expert, but you could use the tibialis posterior, because that, if it's rerouted, can act as a dorsiflexor with perineal nerve damage. But often it depends what setting you're in, and if you've got the local surgical capabilities, and you really have to have good rehab as well afterwards for this. So complications. As with a lot of your trauma injuries, and you'll see it the same with the bigger mixed picture of the polytrauma. So you're going to have that neuropathic pain, And that could also be included in that could be caused by your neuroma. You've got the hypersensitivity, you have injury due to loss of sensation. So this is also why I'm highlighting peripheral nerve injuries, because if you don't have the good sensation, to your foot, to your hand, wherever it might be, patients need to be educated for the safeguards, because they cannot feel that, have that protective sensory feedback. Complications due to edema as well. And also with what we want to also prevent, because we can manage edema and we want to prevent the contractures due to loss of movement. So patients moving and then that position of deformity prolonged, then unnecessary contractures can develop. And then also from wound healing and infection. And also if you get more scar tissue from delayed wound healing and from the infection, that can also have a very detrimental also to the healing recovery of that nerve. Just think about that nerve trying to make its way through along the path, and then you've got a further obstruction in something like scar tissue as well. And ultimately, it's your loss of function for these patients. So as I've mentioned, your nerve injuries, like they are common in earthquakes and often missed. And as we know, it can result in significant disability. And I think really take home to all of you is, you might not be sure, you might see a patient and there's a lot going on and there's a lot you're trying to decide to prioritize. But I think if in the back of your mind, you've got a few things when we talk about the signs and symptoms of nerve injuries, give you more confidence to maybe highlight it. There might be nothing you can do in that moment, if it's not we don't know if it's going to heal or not or regenerate, but there's a lot you can do in that moment to educate the patient and give them basic treatment plan to help to manage the pain or to desensitize or to and prevent contractures with range of movements, and look at functional options as well for them. And also not to be scared to mention it to the medical team, to signpost. It might not be peripheral injury, but rather say something than not. So the reason why I've put these pictures up here, these are cases as well as the patient might not have sustained the peripheral nerve injury from the actual trauma event, an earthquake. It might be due to other things, and I see a lot of this with external fixators. No doctor has tried to cause a peripheral nerve injury, or with such an influx of patients, and sometimes it is life-saving limb salvaging procedures that happen right in the beginning. And so I've had patients where I've picked up signs of peripheral nerve injury, and then I said, oh, can we look at the x-ray? You might not have access to x-ray, hopefully you do, but maybe just signpost the medical team. And if you're not confident to look at x-ray, that's okay too. But to think about this, hopefully this highlights that you can think about other causes of this signs and symptoms of the peripheral nerve injuries. So in these ones, you can see like the one with second from the right at the top, external fixator was nicely rubbing on the ulnar nerve, too long, and then the doctor just unscrewed it a bit, pull it out a bit. And then if they think of the lower leg, think about foot drop. It's common with your perineal nerve on that. Just by the fibular area, often there's a screw around that area, and that can cause problems. So just think about those things. And then with your humeral fractures, I often see with associated radial palsy or brachial plexus. From further top, there's been a traction pull. Yeah. And a lot of edema with it. So I'm not going to go too much in depth about complex regional pain syndrome. I just want you to be aware it's a really complicated condition. It's hard to treat. But it is a rare condition, and what it is marked by chronic pain neuroinflammation and dysautonomia. And there's two types, but it can be chronic and progressive. The big factor with this is that it's disproportionate. The pain that it causes or the patient experiences is disproportionate to the injury. So a lot of the symptoms that we look at, or just the pain symptoms, they're often caused by something else. And I don't want you to sort of deflect from other causes that might be. We won't rule out anything else. So it could be whether it's compartment syndrome, whether it's infection, for example, or whether it's they've got something trapped inside or causing the pain. But I would say that so when you rule out all the other potential causes, this is where a type 2 CRPS is in the presence of a major nerve damage. They might develop this. So the key symptoms here are severe disproportionate pain, allodynia, which is normally pain typically from a non-painful stimulus. So even just a little light touch could be experienced as extreme pain for this person. Abnormal stiffness and swelling, and also again the changes in the sweating and the blood flow, so the autonomic dysfunction, sometimes altered temperature regulation. So with these patients, you don't just leave them to be and think, oh, they don't want to be touched, too much pain. No, these patients is very different. You want to, together with the whole multidisciplinary team, because they'll need to be managed by the whole team, including with medications, is encouraging the movement in a graded way, handling and getting them to use that affected limb, not allowing disuse. So again, on the ideal scenario, if we're looking at the gathering information that we need from the patient, we can, if we've got access to notes or if we find out before we even see this patient, look at the nature of the injury, the associated injuries, if any surgery's been carried out, if they past medical history, the medical medicines they might be taking, and then as well, patient when you're with the patient, really get to understand the pain levels, and the dominance, if it's hand affected, what the dominant hand is. Again, what we usually do, we find out their roles and look at and assess their sensation. So if you just look, and we can learn a lot by looking at the posturing of the hands. Now, I'm sorry, I am going to go on more about hands than legs, but it would be the same concept here. And so looking at the posturing, looking at wounds, where the wounds are, any infections, where the scars are. So this, if it's subacute, where the scars are. Skin texture, when we're talking about if it's sweating too much or really dry skin compared to the area around, looking at any swelling, any muscle, but this will be down the line, the muscle wasting and the deformities. So signs of a missed nerve injury. So again, use Google. Don't worry about remembering everything if you can't, use Google. But I'm not talking about high up the brachial plexus, that peripheral nerves initially, the complex pattern of complex network of nerves higher up around the shoulder area, that'd be your brachial plexus, and then you've got the nerves coming off from the top, but I'm more going to go talk about the median, ulnar, and radial nerve, but you have got the other peripheral nerves that feeds the muscles higher up in the arm. But the classic patterning there with your median nerve is your that eighth thumb positioning or the hand of benediction as well, and then you've got the ulnar nerve where you've got your claw fingers on the other side. Now, depending on how high the ulnar nerve injury is, if it's a lower at a lower level, you get more of a claw than higher up. I think just because of the sake of time, I'm not going to go into too much detail now, but this is all things you can read up more about. And then the radial nerve force, your classic sign is your wrist drop because your extensors are affected. Okay. But with median nerve, it's mostly your flexors. And, you know, within sensation, it's to the radial half, the volar, underneath the area of your hand. Ulnar side sensory impairment would be to the ulnar side of the volar aspect, of the palmar aspect of the hand. And then your radial would be your extensors are affected, extensor muscles, and then just behind the thumb, the index finger, and your sensory loss or impairment. Okay. If we've got time, I'll come back to this. And then sorry, just to go back. So often with the radial nerve, if you've got complex humeral fractures as well, that can be affected with the radial nerve. For your lower limb, just looking at the common injuries, is most often would be your perineal tibial sciatic nerve. And these are important in the control of the ankle foot position, which we need for mobility. So the perineal nerve injury, you would see signs of foot drop. Maybe you've got a weakness in it. And these commonly associated with your fibular fractures of the knee. And again, as I've mentioned before, the pin site. So the patient I had there, he had foot drop there, a very, very hypersensitive foot, and he had a pin site right by the fracture, higher up than about the fibula. And then with the sciatic nerve, you'd get the knee flexion and weakness in knee flexion. Maybe a crush injury, or you've got pelvic or femoral fractures, or from sustained traction to sciatic nerve entrapment. So in terms of assessing motor function, we're going to look at what you do all the time. I think, you know, as therapists, we'll observe. It's good to know your anatomy, because although I haven't had time now to go into detail with each of the peripheral nerve functions and what muscles they feed, if it's a motor nerve, obviously I'm not talking about sensory, the motor nerves then, some of the mixed, then we need to look at, and knowing your anatomy, then you can differentiate. And sometimes you'll get a mixed pattern because it's more than one nerve, peripheral nerve that's been affected. So it might be quite confusing initially. Look first at your active movement, because if it's been a delay in seeing the patient, then maybe they've started developing some soft tissue tightness, some contractures. So make sure that they've got good passive range before you look. Look at the active, but then also just check the passive to make sure that it's not because of contractures that they can't move. Again, intrinsic muscles in the hand. If you're looking at testing them to see it, they're not that powerful. So if it feels a bit weak, it probably you've got another hand to check it's the same. And if you can, try and feel the muscle bellies when you are testing to see if you're going to flicker or feel some kind of contraction. And then generally use the Oxford scale for manual muscle testing. Sensory, the most basic there would be your for protective sensation, as your hot and cold, or your sharp and blunt sensation, for the patient to discriminate that. The 10 test is just a moving light touch, and you're comparing to both sides, and it's literally, you can read up more about that, but it's just getting the patient to rate 0 out of 10 as to what it feels like when you brushing your fingers along the same area on your contralateral side to the side that you're testing, and then they can score that. And then you'll get the 2-point discrimination. I'm not going to talk about monofilaments now, because I don't think that that's appropriate for the context, but it's something down the line that if you have access to them, that can be used. So again, if we're looking at testing tricks that the patients use in terms of for sensation, one thing that people can do if it's difficult to maybe be able to assess the patient, or or if it's a little kid, they're cooperative. Then the wrinkle test is something where you can read up about as well. It's submerging the affected area into sort of a bowl of warm water. Sometimes I say 20 to 30 minutes, and actually then the body sympathetic system. The thing is, you know how you've been in the bath for so long, it wrinkles, and actually find if there's been some sensory nerve impairment, then there might be an area that doesn't wrinkle. And then also just check signs where the pheromones, whereas a patient that is then they're unable to, if you get them to make an O to make sure that they're using the right muscle groups, and then instead of making a D where they're compensating with another set of muscles, when you're trying to differentiate between, say, for example, median nerve injury and your ulnar nerve injury, you might be able to differentiate with that. So when it comes to treating patients, we're looking at it's just maybe the priorities and pain and sensation. You want to target and manage that. You want to prevent stiffness and contractures, and then we're looking at function. So looking at when you're planning and prioritizing, what are your main objectives right there and then, and looking so down the line, if you need to give patients some information, if they're going to go off and you don't know sure if you're not going to follow up immediately, or they're going to be referred to another place, what does the patient need to know then and there that would be helpful to guide them before they're seen again. Again, how often you need to see this patient, if you are able to have them return, depending on your current caseload, and when do you need to refer a patient to another service, and when do you discharge the patient. So with that, we're going to encourage a lot of with function. We're going to look at a lot of the bilateral activities. We're going to looking at patient independence and self-management of treatment techniques. That's really key, I think. Patient independence in daily functional activities, whether that's with some compensatory means or not, and you'll create a problem list and review. So treatment, I can't stress enough, it's advice and education. I think the biggest thing for these patients to know that with a nerve injury, we might not know when we first see this patient if this, and it depends on the team around, the medical team around. If it's been a definitive, they know exactly what the extent of the nerve damage, and if perhaps we're anticipating recovery or not. But with what you do know, you need to advise and educate the patient. And so looking at appropriately guided exercises, sensory retraining, and where and if needed, the splinting and casting. So, and don't forget, it's the basic techniques as well. If you've got a wound that's healed, scar management, thinking about that scarring can also impede the nerve that can cause the nerve symptoms as well. But also it can help to free that area up. Your graded desensitization, your edema management, your splinting and casting, your basic exercises, your functional retraining, home program, and goal setting. So I'm speeding on because of time. We're of time. But when you're teaching the patient, because sometimes with my patients, if I'm sending them off and they might only come back to me in 6 weeks' time, and I've given them a home program. Hopefully, maybe you can see them regularly and sooner. But I have to explain to a patient why I've given them, say initially, they can't move, they're battling to feel a certain area, and I've given them some passive exercises, and I've been telling them to think about the movements, imagine the movements, use other hand to also or like you imagine movement, and then to keep the ranges. But if they're not seeing a change day after day, they have to understand why you're telling them to do it. And we're going to tell them, obviously, because the nerve recovery takes a long time. They might need a splint to support the joints, maybe at rest, maybe for function. And so also mentioning the risks that are associated with the peripheral nerve injuries, but if they can't feel. again, I've mentioned about the realistic recovery timescale, and also and that smoking also delays recovery, especially if they've had, if surgery or not, we know that smoking does delay recovery. And so with these exercises, as possible, if it's 4 to 6 times a day, maybe that's optimistic in the patients, but it's a passive and active if able, unless it's contraindicated. So if there's anything, if they've got a unstable fracture or anything else that we need to bear in mind, sometimes this might be, we are adapting around what other injuries the patient is presenting with. Remember that we don't want to overstretch or traction the affected nerve. If they can, encourage a weight bearing and using the affected limb and normal movement patterns as possible. Again, this whole idea of the cortical representation. So we look at sensory re-education. So maintaining cortical representation plays a vital role in helping individuals recover sensory or motor functions after the trauma injury. So rehab techniques aim to stimulate the brain's ability to adapt and organize itself. So, and there's that word you might have heard of with the neuroplasticity there. So, in rehab, we help with our techniques and our exercises, try and maintain cortical representation. So with things like sensory education and nerve injuries, and the exercises are designed to improve sensory feedback and reestablish the brain's connection to specific body parts. Now, it depends on the severity of the sensory impairment, so we might have to peel it right back and look at even basics of like laterality. But again, it's talking this through with the patient and giving them the advice. Might be using the other hand for bilateral influence, and then use the other senses. You imagine the movements, using your vision to help guide and prompt. We talk about, I think you're all very familiar with texture retraining and the grading and that, and dexterity and differentiation. And then there is, if you want to look up Moberg pickup test, but because of time again, I'm going to race on. But the Moberg pickup test is a very simple test. If we're looking down the line, it's to help with functional sensibility. So it's something that you can adapt as well for what your assessment aims would be. But you're taking 10 everyday similar objects. Maybe you've got like a screw, a coin, make a coin, pen, paperclip, and it's going to be similar temperature as well. But they're ones, and you can then time a patient from picking up, putting them into a little box or container, and then you blindfold them and you repeat it, and then you might get them blindfolded to pick it up and feel it and identify it as well. And you can do the timed retest as well. Okay. So in terms of splinting, that's a big topic in itself. I've splinted lots of patients with peripheral nerve injuries, but you got to think about the aims and purpose behind it. So with any splinting, my big thing is the safeguards that go with it. If you're going to issue a splint, the patient really needs to understand why they've got it, for how long they're supposed to, when and how long they're supposed to wear it for, and any safeguards in terms of for pressure care advice, and if there's any concerns, what it should look out for. So, and again, this can be splints might help to prevent contractures, improve the range of movement if contractures are setting in, zero splinting, or enhance function for a functional position. For example, with your median nerve injury, it could be a help to abduct the thumb a bit. You've got your ulnar, for your ulnar nerve injury, you've got your claw, your anti-claw, your blocking splint there. A radial nerve, it might be to help to lift the wrist into more extension. And sometimes with the fingers, you can too, and the thumb. So, but I think if you're going to be making splint, just think about the anatomical landmarks or the pressure points, the areas, infection control if it's washable. And also if a patient, if you're fluctuating swelling, if you're going to be issuing a splint and then patient maybe increasing swelling increases or decreases, or they've had some dressings on, they come off, that splint shape is going to change. So it's a plan that you can check the splint if it's custom made and for follow-up there. And yeah, the monitoring. It might be that there are other things that you can use to provide the same positional support for the patient. It doesn't have to be expensive thermoplastic splint, or you might have access to custom made splints as well. So again, that's just going through for the patient, the safeguards, actually educating them, how and why, timeframes, strict pressure checks. Also, please make sure that the patient or the caregiver knows how to take the splint on and off. I actually get my patients to practice. It sounds silly, but often the patient might get a little confused putting it back on again. And so I often take pictures that you can, or a photo of how it should be fitting in terms of where it should be fitting, and the strapping as well, no tight strapping. If a patient has got sensory issues, it might be a contraindication, maybe not if they've got good ability to do strict pressure checks and skin checks. But if a patient hasn't got the cognitive ability to be able to identify problems, and there's no carer to oversee the management, that might be a contraindication to issuing a splint. Again, it shouldn't cause pain. And just think about the skin condition as well. You don't want to compromise skin integrity and also with healing wounds. So just in summary, the nightmare scenario with patients when who present with peripheral nerve injuries or complex injuries is infection, because that can just set everything back or exacerbate symptoms, as with poor wound healing, creates more scar tissue, where you've got late identification of the peripheral nerve injury, which then often has led to joint contractures. I see that a lot here. I see a lot of some of the warm wounded coming back, and they've had a missed peripheral nerve injury. They've gone off because their wounds have healed, but they've come back with tight contractures, because they haven't had any education prior to that. Could be from secondary injuries. I think there are lots of different reasons. You could get that from some of the procedures that have been carried out. It could be as well, if I think about patients in sustaining injury because they can't feel well, haven't got good sensation. Also, if they've had the surgery or tried to repair or left, there's a lack of regeneration. They've got the hypersensitivity to deal with. They have now also maybe developed trip compensatory movement patterns as well. And then you've got the complex regional pain syndrome. So that's your nightmare scenarios, which hopefully we won't have too many of, or none at all. But we can play a role in trying to minimize that, reduce that, or prevent some. And then thinking about our basics in terms of anatomy when you're assessing, and maybe when you can helps you to have a look and identify some missed peripheral nerve injuries, and then just how we go about our basic assessment with our patients to be able to plan treatment and prioritize. Softening scar tissue, I mean, that's with all your patients, right? With trauma injuries, preventing the contractures, and controlling the pain and trying to desensitize. The patient's not going to do his exercises or want to move it if we don't teach them technique to try and reduce that pain and desensitize. And then think always about function, how to incorporate that affected limb as well, and make the person more functional. Okay. So I know that was really rushed in the end, but I am aware of time. Okay, I'll stop sharing.
Thank you, Debbie, for such a
Yeah.
comprehensive and clinically rich presentation. I put my video on, apologies. Your exploration of peripheral nerve anatomy and rehabilitation techniques has been incredibly valuable, especially in the context of emergency care. And you've given us practical insights that can be applied even in challenging conditions. Um, I'm aware of the time. As I mentioned earlier, we have had one question, but if anybody has any other questions, could they please post them in the Q&A function and we can answer them after the session. Debbie, there was a question about somebody asking what the time frame for the acute phase would be. I don't know if you have any any thoughts on that.
Sorry, does someone want to answer in terms of the acute phase for repair or just for treatment?
It's not clear. I assume it's seeing if anybody's written any more detail. The acute phase, I could imagine it would be sort of the surgical part. Difficult to know. If the person who wrote that could ask a more detailed question, it would be really appreciated. I'm just seeing if there are any other questions. I can see people putting their details in the chat, which is really helpful for us to be able to follow up. I can also post in the link to the subsequent webinar that will be taking place on the 9th of April at the same time, hosted by World Physiotherapy. Again, thank you, Debbie. I can see that there are questions coming in. We are out of time, sadly, but people, would everybody please ask their questions? And we've got clarification on what we mean by the acute phase. So we'll be able to answer you following the session. Thank you for asking your questions. We'll be very happy to follow up and post our responses as part of this video when it's uploaded following the session. Again, it's been really important that you've been able to attend, everybody. And Debbie, again, thank you for the work that you're doing and also the presentation that you've taken time out to prepare and help share and support people who are working in these challenging situations and the communities that we work with too. So I will thank everybody for attending. We look forward to seeing you at future webinars and following up with you, everybody who's left their contact information. So on that note, we will thank you and we will see you soon. And thank you again, Debbie. We'll speak soon.
Thank you very much.